let's talk about this. This is interesting stuff too. Okay, so childhood and neurodevelopmental disorders. Not a lot of people want to even be mental health nurses, but there are not even enough mental health nurses for children, right? So we're going to talk about different types, that Proctor covers that's important for this class regarding childhood disorders, but there are lack of services and premature termination of treatment in regards to mental health in the peds demographic. Okay, there are barriers to excuse me to assessing, diagnosing, or treating younger people. Okay, disruption to a normal pattern of childhood development. Absolutely. 20% of children and adolescents in the US suffer from a major mental illness that causes significant impairment. Right? There's a lack of education when it comes to psych and kids. Right? That's why there's this barrier for adequate treatment. Okay? And then there are all these risk factors. Okay? So, the one time I was on the PEDS unit with my students, I noticed all of this. And this is true. So, familial risk factors that correlate with psychiatric disorders in children include severe marital discord, lack of family structure, whatever your family structure is, lack of that. Having parents who provide comfort, who provide shelter, who provide discipline, there's a disruption in that. Okay, lots of foster care patients on the psych unit. Okay, low socioeconomic status. Okay, this is the truth, but I can also debate this because it doesn't matter where you are on the economic scale. It affects the poor and the rich and the middle class. It affects everybody. Larger families and overcrowding families, right? You have more kids in your family. There's always, you know, the youngest always fail to get the same amount of attention as the elders, right? Or the older siblings take care of the younger. So there is no appropriate dynamic of parent and child, right? Um, criminal activity. I told you guys about the girl who was trafficked by her father. Yes, right. There's lots of children on the psych unit who come from these types of family, right, or family backgrounds, right? Maternal psychiatric disorders. Interesting how that happens. The maternal genetic plays a higher role than the paternal one. Foster care placement, absolutely. Okay, it's heartbreaking. I want to some of these kids are right. Me too. I was I can't work with kids. I just can't do it. I love them too much. So what I've noticed is that neglect is the most prevalent form of child abuse in the U.S., which leads to psych disorders. Okay, it's a common factor I've noticed when I've been working with kids. Okay, I've got some more stories with kids. Okay, resilience. How many times have I mentioned? By the way, can you guys hear noise in the background from my end? A bit. Okay. Apologies. We are moving and there's a whole lot of chaos going on. Ignore that, just pay attention to me, right? Resiliency. Thank you guys for understanding. Resiliency. So not every child is at a higher risk, right? Not every child who is part of this demographic right here is going to be, you know, is not going to be resilient. There are children who are resilient, and although they go through all of these things that place them at a higher risk for mental health illnesses, some of them don't because of resiliency, right? The ability to adapt to changes in the environment. There are lots of foster care kids who adapt easily and are resilient and optimistic. They're able to form nurturing relationships with older adults. Ability to distance self from emotional chaos, good social intelligence, good problem solving skills, ability to perceive long term future. So, um, there are so many children who come from neglectful families but are still able to form these positive relationships moving forward. So don't always think that every child coming from that type of background is going to end up in some form of psychiatric setting. Okay, that's what I want you guys to understand here. Okay, now there's so many interventions we incorporate when we care for kids, but therapy is huge, and this is because we gather our assessment here, right? When we have family therapy, it's not because well, obviously we need to have family therapy. Every time you care for a child, family is always involved. But we're gathering assessment. How are they, you know, how are they interacting with their parents? How are they, are the parents responding for them? Are we suspecting abuse? All of that comes into play. Group therapy. How are they interacting with others? Behavioral. Um, with kids on the psych unit, behavior is a big issue. They lack the discipline outside of the setting, which is what brings them to a psych setting. So we incorporate cognitive behavioral therapy. Behavioral therapy. So there was this one time I was on the unit with my students, and just this one day, the kids were all just, it was like, I don't know, was it Friday the 13th? Was it a full moon? I have no idea, but they were just rowdy, okay? It's okay. You use the least restrictive method to calm, you know, the unit down. The doctor comes out of her room and seems like she's had enough, which doesn't make sense because, yeah. And she just says to everybody, to all the kids, you're getting booty juice, you're getting booty juice, you're getting booty juice, everyone's getting booty juice, which basically means everyone got a chemical restraint. And they knew what it was. They started saying, no, I don't want it, I don't want it, I don't want it. But everyone on the unit got booty juice. So every time the doctor would say booty juice, they knew they were going to get some form of injection. I mean, how bad is that? That's not what behavioral therapy is supposed to be like, okay? Disruptive behavior management, timeout, we use it with children. You will forever have that ingrained in your head. Some interesting things you're going to see along the way when you guys become nurses. There's so many different people on planet Earth that you're like, really? What the heck is going on? Play therapy, music does wonders in psych. I love music. I always incorporate, when I'm on the unit and there's a piano or anything like that, I always incorporate it. Play piano. Some of the patients um, really are really great singers. They incorporate all of that into their care, and it works. Now we're going to talk about certain meds too. Okay. I'm not going to dive into this. I just went over it, but with group therapy, we use it for younger children, grade school children, adolescents, right? With younger children, play, because that's how we assess for ideas, how they interact, where's their development, okay? We use that with ADHD, with autism, right? And then with grade school, play and learning skills and speech, because at that point, they're kind of, you know, we try to decide, hey, are they where they're supposed to be developmentally? Adolescents, identifying emotions, right? At that point, in your teens, emotions come into play. How you verbalize your feelings come into play. And then cognitive behavioral therapy. It just kind of speaks for itself. Famous cognitive behavioral therapy. I won't even elaborate at this point. Let's talk about the things we're going to talk about today. Communication, motor disorders, specific learning disorders, IDD, ASD, autism. Don't confuse it with ASD, acute stress disorder, and attention deficit hyperactivity disorder. Okay? We're going to incorporate all of that. We're going to talk about it. Okay. Okay, so I don't dive too much into communication, but I want you guys to understand something. Speech disorders, problems in making sounds. So speech and language disorders, we see them in autism and ADHD, okay? And a few of the other ones we're going to talk about. They're all signs and symptoms of autism and ADHD. They're incorporated in one way or another. So difficulty understanding or using words in context and appropriately, verbalizing what you have to say. So language disorders may be evident in ability by following directions. Autism and ADHD, we're going to talk about it. Very compulsive, right? Unable to, very hyperactive. Expressive language disorder, impairment in ability to develop skills to communicate verbally or through sign language. We're going to talk about that in autism and ADHD. Social communication disorder. I mean, this is one of the main signs and symptoms in ADHD and autism. Okay, we're going to talk about that. Okay, tic disorder, motor disorders. Sorry. Okay, so tic disorder. Maybe you guys have seen, TikTok is my source again. Maybe you guys have seen that she has a TikTok account, like a really famous one, and she films her tics as they come along to be. She's the one that whistles, kind of barks sometimes, maybe kind of screams out an F word here and there. I'll try to find it and send it to you guys. Tic disorder. This is what this is: sudden, non-rhythmic, involuntary, rapid motor, repetitive movements or vocalizations. Okay, so it's Tourette's and persistent motor or vocal tic disorder. They kind of differ a bit, right? So with Tourette's, it's multiple motor tics and at least one vocal tic for more than 1 year. So many tics. Okay, and persistent motor or vocal tic, single. It's either one or multiple, but not both. Alternate. Okay, that's the difference. Okay, so the way we treat behavioral behavioral techniques, medications. Again, there's no specific medication for tic disorder. We use it to target the behavior. And deep brain stimulation, it's surgically implanted device, electrode within the brain. So stimulation is delivered by the electrode by a pacemaker that's placed under the skin. Okay, it kind of works. It kind of works. The one problem with this is that lots of patients get they can get an infection um, when it comes to the electrode. So sometimes you implant it and it works, and then you can get an infection and you kind of have to remove it. Okay, it does decrease the tics big time. Big time. It works. It works big time. I'm gonna have to find videos. I'm gonna have them saved and send them to you guys so you guys can see it visually. That's the sad part, right? So let's go over Tourette's a little more. Okay, the essential feature of Tourette's is the presence of multiple motor tics and one or more vocal tic. Okay, repetitive, stereotyped, involuntary, right? They're not in control of this. Movement and vocalization called tics. Okay, onset maybe as early as 2 years, but most commonly around age 6 or 7. Early onset. If you have tic disorder, if your patient has tic disorder, they've probably been diagnosed as a child. Okay, more common in boys than girls, which is interesting because the ones I've cared for have been all female. I haven't cared for a guy with tic disorder. Okay, but statistically more common with boys, according to the book. What are the tics when we assess them? They can be squeaks, grunts, barks, sniff, snort, cough. Okay, I'm gonna have to find it. It's such a cool video. Um, and in rare instances, a complex vocal tic involving the uttering of obscenity. Yeah. Using a whole bunch of cuss words, squeaks, grunts, barks, sniff. Sometimes, not sometimes, but a lot of the times it can be very risk for injury. They can hit the person next to them. They can fall to the ground, break things. Um, risk for injury is huge with them. Echolalia is very common signs. You guys remember this? Repeating words said by others. Remember we learned this in Schizo, week 2? Echolalia. Yeah. We're also going to learn this in echolalia. Alzheimer's. Very common in Alzheimer's. Okay. Now, how do we care? How do we care? How do we care for our patients who have tic disorder? So nursing care of the client with Tourette's disorder is aimed at safety, because risk for injury. Remember, they can fall to the ground, they can hit others, they can break things. Guys, in psych, safety, if your answer is a safety answer, choose it because it's probably the right one. Okay, encouraging interpersonal interaction using appropriate behavior. There's lots of bullying going on with kids who have Tourette's, or people who have Tourette's. Lots of bullying going on. So lack of socialization is very common. So you want to encourage interaction using appropriate behaviors. Okay, that way you promote increased feelings of self-worth. Okay, they kind of feel really down too. They know what's going on with them. They don't want to experience those tics. It's involuntary. Now, a lot of the times, their loved ones, their family members, friends, they think that their child is faking. My friend is faking all these tics. Like, what's up with that? You're going to educate and you're going to say, no, it's real. Okay? Illness is real. It can change in frequency and severity. If it's severe, it doesn't mean it's always going to be severe. It comes and it goes depending on how anxious they are. Okay? Bodies react to anxiety very differently. Okay? So, it's real. Pharmacology. Okay, so for facial spasms, because lots of tics involve the facial expressions, we use MyoBlock. Very effective. Very effective. Know this? We use SSRI because we want to reduce the. So SSRIs, they can target anxiety and depression. So it's like dual usage, two birds, one stone, right? And then we use lots of behavioral meds, anti-psych, risperidol, Abilify. It targets the irritability, aggression, temper tantrums, and self-injury. Because when our patients escalate in the schizo week that we discussed, we use all these meds. These were our safety drugs, right? Um, our rescue meds. So it's the behavior that we target. Okay, it makes sense, right? There's no specific drug for Tourette's. It's the behavior. Okay. I don't go in detail, but specific learning disorders, you guys know dyslexia. Sometimes I feel like I'm dyslexic. I'm not diagnosed, but sometimes I read things just not what they are. Okay. Dyscalculia, math, numbers. Okay. Dysgraphia, written expression, unable to. I don't go too in depth, but know the definitions. Open up that ATI book, or go to PALS, right, and look into it. Okay, IDD. I know that the proctor loves this. I use this on the exam. So below average intelligence and set of life skills present before age 18. So before age 18, people with IDD, right? Below average intelligence and set of life skills. We notice them. So these are the guys who are diagnosed with Down syndrome, fetal alcohol syndrome. They need consistent assistance with everything. So I want to say that they reach up to second grade level. Okay, so to have a family is very difficult for these guys. In rare occasions, we do see that with Down syndrome they can, but we're talking test taking world. It's very difficult to have this whole family planning dynamic going on. Okay, intellectual planning, the functioning, deficits in reasoning, problem solving, planning, judgment, abstract thinking, academic ability, as those individuals who don't have IDD, right, of their same age group. Social functioning, impaired communication, impaired language, interpreting and acting on social cues, and regulating emotions, managing age appropriate activities of ADLs, functioning at school, performing self care. So they need consistent help. Someone needs to be there for them at all times, right? At all times. Practical aspects of daily life are impacted by deficit in managing age appropriate activities of daily living, right? Such as going to school, right? They need assistance with everything, right? I think there are like 3 million cases per year with IDD. That's quite a lot. It's quite a lot. Hmm? Okay, conduct disorder. Okay, so persistent pattern of behavior that violates the rights of others or rules or norms of society. So these are the guys who are aggressive towards people and animals. Kick the dog, kick the cat, kill the bird, choke the bird. Okay, destruction of property, theft, violation of rules, my way or the freaking highway. Okay, they don't care. They're bullies. Their anger is justified. I don't care if I'm breaking the rules. I don't give a shit. That's exactly. These are the guys who later in life end up being serial killers. Wasn't Ted Bundy one of those? Didn't he like killed animals first? Am I wrong? Am I mixing him up with a different serial killer? Or he was, right? There you go. Michael Myers, too. That's true. Most are. So, again, I don't work with kids, but I was on the unit with my students, and there was this one kid who was like 9 or 10, and my goodness, he was not following the rules set for him. Cussing, okay, just doing whatever the heck he wanted to. So your nursing care is to set limits no matter what. You're not their best friend. You're kind, you're caring, but matter of fact, limits. You can't do this and you can't do that. Like that's it. You're setting the limit for him. So I was on the unit and this kid just the limits just wasn't working. He was one of the ones who got booty juice. And we looked at his chart later. We were discussing him during post conference. and he was on the unit because he was diagnosed with conduct disorder. And the reason why he was there is he took a spatula and he beat the crap out of his grandparents, like bleeding, like he just beat the crap out of them. Okay, I was just like, oh gosh. Huh. Guess what? He was abused by his parents who were in prison, right? There's always a history, always a freaking history, and it's horrible. But yeah, he took a spatula, a freaking spatula, and he beat the crap out of his parents, out of his grandparents. Right? Yeah, and he didn't care. His aggression, his behavior is justified. Huh. Ay, ay, ay. Why is there a lack of? You know what? Kids, their histories, like the kids on the psych unit, it's very deep. It runs deep, and it's very difficult. There's a whole lot of it's very difficult. Like I told you about booty juice, right? It's very hard. Sometimes it's like you kind of have to justify what you do, and oftentimes you can't on the ped psych floor. It's really hard. A lot of the kids on the unit are those who come from backgrounds where their parents have abused them extensively, or they're in foster care and they've tried to commit suicide. I mean, it's very hard. It's very hard. I have a hard time just thinking about it. Am I making sense? It's just it's beyond that. It's heavy. It's very very heavy. Yeah, extremely heavy. I have a hard time with that. Yeah, yeah. That's just why. Yeah. So RAD, reactive attachment disorder. So for this, I just want you to know the definition. So emotionally withdrawn and rarely directs attachments towards the family and rarely seeks comfort when in distress. Um, so usually kids, when they're in distress, what they go, I want my mom, I want my dad. They seek comfort from someone who's their, about their, I don't know, the comfort figure. So kids with reactive attachment disorder, they don't. They're withdrawn completely. Okay. They're usually secluded and on their own. They will stay in their room. It's them. You want to encourage them to get out of the room and participate in activity. You know, don't enable them and tell them, "Yeah, I'll bring your lunch to your room." Get them out of the room. Have them uh, interact. You know, can they change as they grow? For rat, so with cognitive behavioral therapy, they can change as they grow. For reactive attachment disorder, yes. Yeah. With conduct disorder, it's a little difficult. You can change, but it's really hard for conduct disorder. Hope I made sense. Autism. Alrighty. So the spectrum is quite wide. Quite wide. A lot of the times we meet people, we can't tell that they have autism, but they do have. So that's why it's very wide. It's like a spectrum of different stages and different levels, right? For test taking purposes, we're talking about, I don't want to say worst case scenario. That's the wrong word. Highest acuity level is the best way I'm going to say it. Okay. So, neurological disorder that causes behavioral, psychological problems, right? So, these guys at the highest acuity level, impaired social interaction, right? Impulsive, repetitive behavior, lots of OCD, specific obsessions, okay? Lack of eye contact, unable to look and focus, okay? Speech delay, unable to communicate, there's a cognitive impairment, and very hard time adapting to a routine change. So that's why everything is structured in their care. The deficits must be taken in the context of the child's developmental level. That's how we assess, that's how the doctor assesses, right? The nurse, um, based off, if the child is 5 years old, are they meeting their milestones? That's how we decide, is there a delay in their developmental stage, So, oh my gosh, who's annoyed by my cough? Because I am. I can't, like, every week I've been coughing. I can't take it. It's allergies, I swear. I get tested every week for work and it's always negative. Thank God. Not caused by a vaccine. Thanks. Thank you. Thank you. Thanks, guys. I'll keep commenting. Not caused by vaccines. Very, I don't want to say very debatable. I will not like take a stance on this because it's this huge debate. There's like a side that says it's caused by vaccines, the other side says that it's not caused by vaccines. I don't know. According to our science, it's not. So it's this huge debate, right? Polygenetic disorder that causes, I mean, that may affect brain structure. I don't go in depth about the brain structure with autism. But I think at this point we understand that with all these psych disorders, there is a brain structure, like a little abnormality of that, right? So basically, with autism, impairs ability to communicate and interact. Okay, difficulty communicating, difficulty interacting with others, leading to social impairment and obsessive interests. Okay, are we good, guys? Right, we are good. Makes sense, right? So, assessment, developmental delay, right? Parent peer child relationship. Um, so when I again I don't work with kids, but when we were on the unit with my students, we came across certain kids with autism, and the one thing I've noticed when I'm assessing them, especially when they're in distress or they've been abused, and there is a parent peer child, like there is some form of strain between parent and child, continuously rocks in place for 30 minutes is a key sign. When they're rocking back and forth for at least 30 minutes to an hour, I know there's something going on. There's some form of anxiety. That's a key assessment I want you guys to focus on. Okay. Another developmental that I kind of talked about that, right? So they're because of their speech delay, their cognitive impairments, parents can abuse them for this, right? Not knowing how to care for them. It's that unwanted child, let's say, who has autism, who has all these issues. So bullying and abuse come into play, and one of the assessment factors is continuously rocking in place for 30 minutes. Does that make sense? How I just wanted to connect that for you guys, okay? Um, so we're thinking very compulsive behavior here, okay? So impaired social interaction, activity intolerance, impaired verbal communication. So they have a hard time with that, okay? Communicating, getting their thought across, focusing. So when you're talking to them face to face, look them in the eye when you're approaching them, okay? So they can focus that you're talking to them, okay? And high risk for trauma, risk for injury because of compulsive behavior. They can randomly fall to the floor and hurt themselves. Throwing toys, okay? Throwing things, bruising themselves, hurting themselves, all of that comes into play, okay? Very compulsive. So declutter the entire environment. Declutter it. Safety. Safety, communication, and self-care. That's your outcome. Those are your goals. Okay? We good, you guys? We good, we good, we good? Right? Head banging is one of them I noticed. Rocking back and forth, head banging against the wall. Okay? What? You watched the TikTok video where they bathe the kids with bleach because they think it will cure autism? What TikTok is that? Please send it to me. Oh my gosh. This is on TikTok? Please do send it to me. Unforgiving. Interventions. Remember when you're caring for kids, parents come into play, right? You incorporate kids. Consult with parents to participate in child's care and treatment plan. Always, okay? Encourage verbal communication. Always, because they have a problem with that. Short to the point instruction. Short to the point. Identify desired behavior and acknowledge and model behavior. Model. Okay? A lot of the times they're throwing, kicking, screaming. You tell them, hey, that's not okay. Right? Communicate with them. Short to the point. Limit self stimulating ritualistic behavior by providing alternative play. Monitor child's behavior for safety, decrease stimuli. So remember, OCD, ritualistic, slowly but surely, don't have them quit cold turkey. Same thing applies for kids. Allow them, but limit. Okay? Consistent environment, consistent schedule, apologies, structured environment. If you're going to change the structure and schedule, do it very slowly and gradually. Let's not induce a panic attack, okay? So slowly make a change, okay? Warn them. Okay, so did I skip a slide? What? Or did I go back? Okay, there we are. So, ADHD. So, psychiatric condition characterized by inattentiveness, hyperactivity, impulsivity. The major signs and symptoms: impaired social and academic functioning, inability to focus, hyperactive, impulsive, compulsive. Biological influence: genetics come into play, biochemical diathesis stress model, anatomical brain abnormalities, right? Prenatal, perinatal, and postnatal factors. I don't dive deep into the biological influences. It's too physiology. Doesn't matter to me. Okay. Now, our assessment findings in someone who has ADHD: difficulty in performing age-appropriate tasks, inability to actually concentrate. Okay. Um, so if they're 12 and they're supposed to, I don't know what the 12-year-olds do. Like if they're supposed to be in school and focus and play, even sports, very difficult. Very, okay? Highly distractible, extremely limited attention span. Very hard for them to focus, okay? Very hard for them. Um, these are the kids in school who constantly talk and can't do a little well because it takes them time to absorb everything. Okay, difficulty performing satisfactory relationships. They can't form friendships. Okay, they can't. It's very hard for them to do so. Demonstrates behavior that inhibit acceptable social interaction. So their impulsivity prevents them from actually forming a meaningful relationship. Okay, and accident prone. Safety is priority. Make sure you declutter the darn environment again. Okay, impulsivity. I even bolded all this stuff. Disruptive, intrusive when they're in group therapy. Okay, excessive levels of activity, restlessness, irritable, fidgeting. Literally, I'm not kidding. This is a perfect description. Low frustration. They get frustrated easy. Very, and temper outbursts. Big time. Big time. So, what do we do? So safety's priority, always and forever. Ensure that the client remains free of injury. Declutter environment. Decrease stimuli always. Okay. Now you want them to form relationships and have a structured environment with consistent rules because they don't like to follow them. So you incorporate play that has to do with another person to encourage interaction and social skills, right? So table tennis, making pottery. I know why it says potty. Pottery, okay. Um, chess, things that have to, kind of like it helps you to maintain that relationship thing going on, which increases your feelings of self-worth. Praise them for being able to complete a certain task. Again, decrease stimuli, fostering motivation for compliance with tasks. And just said that, yes, you did it. You completed this. Okay. Social skills training. Child recognizes impact of behavior on others. Improve relationships with others. So when you foster social skills, they'll realize that appropriate skills allows them to have relationships and friends because a lot of the kids with ADHD don't have friends. And this is why you're fostering social skills training. Cognitive behavioral therapy, right? Provide meds in the morning to prevent insomnia. We're going to talk about that. And then teaching, anything you do it in the morning because this is when they're going to take their meds, so it'll be effective. And you provide frequent breaks so they can focus. Okay? Teach academics in the morning, all activities done in the morning with frequent rest periods, frequent breaks. Okay? So, evaluation. Okay. How do you know if your patient's doing better who has ADHD? Examine client's behavior. After you've implemented all your nursing interventions and you've started them on meds and you want to evaluate if it's all working, examine client's behavior. Okay, examine client's behavior, and that's how you know that they're doing great. Does that make sense, you guys? don't dive deep into this slide. Assess child specialty care for treatment of depression, family involvement, stimulant. We're going to talk about stimulants right now. Antipsychotic treatment for childhood psychosis, completion. I don't dive deep into this. Okay. Okay. Stimulants. These are the main meds of today. So we're going to talk about stimulants, central nervous system um, stimulants. These are controlled substances, highly addictive. Okay? Now, I don't know why this is doing this. Huh. I decided to be cool. Okay, so actions and side effects are different for children and adults. The dosages are completely different. We have to consider height, weight, absorption, effect. We have to consider all of it. Developmental considerations, absorption, excretion, sites of action, and how toxic it is for the child. However, the benefits of these stimulants outweigh the risks. Okay, this is why stimulants are used a lot with children who have ADHD. Okay, so we go for stimulants. Okay, so the main side effects: insomnia, sleep disturbances, and weight loss, which is kind of crazy because, well, we gotta monitor that. Our child is developing, and you don't want them to lose a whole lot of weight, right? You gotta monitor their growth. Okay, monitor their sleep pattern, monitor weight loss. Do not administer at night because these drugs cause insomnia, right? You don't want to give it at night. They're not going to sleep. Give them at 30 to 45 minutes before meals. Before meals or with breakfast. It's not supposed to say meals, it's breakfast time. Before or with, right? Monitor weight and height during therapy because it stunts growth, stunts development, and that's what you want to target. With children, that's the whole point. Where are you in your development? Okay? Now, so we're going to talk about methylphenidates and amphetamines. They're pretty much the same. With methylphenidates, it's the amphetamines plus the methylphenidates together. It's a form of med, basically. And amphetamines is just the amphetamines, okay? They're both stimulants, highly addictive. The way I want you to study this is classify them based off of time frame, okay? These drugs work based off of how long they last in your body. So when you're studying, you're taking my slides, and then you're taking the med sheets, and that's how you're studying them. Okay. So short acting. These drugs under this category, which you're gonna memorize the shit out of, 3 to 4 hours. That's how long they last. So when you read a question and it says, my child who's a 7-year-old is on methylene oral solution, it's the liquid form. Kids like liquid, right? Tastes like grape. They're gonna comply and take the med. You're gonna educate the family and say, hey, well, this is gonna last you 3 to 4 hours. Does that make sense what I'm trying to say? So it's time frame. It's all about educating them on how long this medication is going to last. So these are short acting, 3 to 4 hours. Then we have 4 to 8 hours. Okay, very commonly administered. So SR stands for slow release. Last longer, slowly release throughout your body. Okay, Ritalin, methylene, ER, what is it? Enteric release. I forgot what it stands for, but it doesn't matter. But these drugs last 4 to 8 hours. Again, you're gonna educate the parents. Hey, remember you're gonna give it in the morning with breakfast, before, after, as long as it's with food, in the morning, so it can last you the school time that they're gonna be in. Does that make sense? That's how this works. Intermediate acting, and then we have our long acting. Okay, it's 8 to 12 hours. Okay, we've got our Ritalin, we've got our all of these drugs very commonly used. The first one, Concerta, this is our first choice when someone is newly diagnosed with ADHD. The doctors go for that one. It's good. It lasts at least 12 hours. Okay, lasts at least 12 hours, and just know that the doctor's going to go for that one first. Daytrana, we use it a lot too. This is a patch. Okay, remember, these are stimulants. These are highly addictive. So you want to educate the person who is on Daytrana, which is going to last you 8 to 12 hours. You're going to place the patch on the hip daily and leave it on for 9 hours only. Not because it's not going to work after 9 hours, but because you don't want to get too much. That's too much stimulant. Okay, you're going to remove it. It's like increasing the dosage of your meth. This is what this is. It's meth. Okay, and you're going to get irritation, and you don't want to have it on for too long. Now remember, You're going to remove it. You're not going to toss it in the trash. You're not going to put it in a paper bag, toss it in like the big bins outside. You're going to flush it down the toilet because you don't want someone to grab it and use it on themselves. It's still active after 9 hours. It's just you don't need it after 9 hours. Okay? Am I making sense, you guys? Right? Can we use that to study for the final? Can you use what, this? My slide? Oh, oh, brain freeze. You mean Daytrana? Listen, what you do on your off time is none of my concern. Listen, I know a lot of people who do use it. Just be careful. You don't need it. Do you know what I mean? If you use it to study, you gotta use it to take the test too. There's a huge crash period. I specialize in substance abuse, and patients who come off of meth, there's this huge crash period. It's the worst period of your lifetime. Don't put yourself through it. I'm gonna say no. But you know what? You can do whatever you want. You can use my slide to study. That's perfect. Oh, you guys. Hey, it's okay. I rotate absolutely to reduce irritation. To reduce irritation. Fun stuff. Fun stuff. When I was doing clinical with my students for 2.5 years, I noticed easily how some people did use meth and then like they would come back. By the way, when you come off of meth, your skin breaks out completely. Yeah. So watch out. So um, yeah, be careful, guys. Don't do drugs. I can't wait till we talk about drugs next week. That's my thing. I specialize in that stuff. Scary stuff, guys. Then we have our amphetamines. Same thing. Time frame. Time frame. That's how you're going to educate. Okay? Dexedrine. Okay? Dextrostat. Adderall. Vyvanse is so freaking popular. So, all these drugs, by the way, you give in the morning with breakfast, right? You monitor for height and weight because they give insomnia. You give in the morning. That's why. So you can educate them. Hey, if my patient's on Vyvanse, 8 to 12 hours. If they're on Adderall, 4 to 8 hours. Okay, if they're on a short-acting drug, 3 to 5 hours. Does that make sense? That's what I want you to know. Okay. Possible side effects: loss of appetite, weight loss, insomnia and restlessness, which is why you give in the morning, growth delay, stunts it, skin irritations from Daytrana. Depression is when you come off of it, you hit a really bad depressive state, cardiovascular effects, psychotic symptoms. I don't target that. Hallucinations. I don't go over this slide. I'm not sure why I include. I think I used to have a test question. How often do you weigh them? There is no specific like thing that you there's a specific how often. Yeah, you just monitor their weight to make sure they don't lose a lot of weight. You go weight every 2 months. Okay. Yeah. Depends on how your doctor decides to. Yeah. It won't be a test question. It won't be a proctored question. Nursing considerations: do not cut or chew sustained release. So everything that says SR, don't chew it, don't cut it, don't crush it. Regular schedule, rigid, regular schedule on time, because you want to take effect. There's always a prescription. This is not something you get over the counter. This one, yeah, don't focus on it. It's fine. I used to have a question on this, but I removed it. It's okay. Store it away because you can build a tolerance. This is an addictive drug. Bad, right? Development of substance abuse disorder. Even patients who are prescribed, sometimes the doctor doesn't give them the appropriate dose, so it doesn't work. So the patients who are on these, they increase the dosage themselves. I have a couple of friends who are on this, and Like they tell me themselves that we've increased the dose and like we can't decide what works and what doesn't. So be very careful. This develops into substance use disorder. Now, we talked about stimulants. Now there's a non-stimulant. It's an SNRI, remember? It's an antidepressant, but we use it for ADHD as a non-stimulant. Doesn't build you don't build a tolerance to it. You're not going to get addicted to it. The thing is that this is not good with hyperactivity. It's good for your attention span. How will you focus? So it doesn't give you sedation. Well, it gives you sedation. So you take it at night so you can, as opposed to methylphenidates and the amphetamines. You can't take it at night, but this you can. Must be taken for at least 1 month to titrate and another month to develop to evaluate how effective this medicine. So it takes some time to kick in, right? Stimulants take effect right away. Non-stimulants don't. It takes some time. Okay. So the good thing with this drug is it's not addictive. Some other second line treatment with Strattera also, right? So Strattera, Wellbutrin, guanfacine, um, they're non-stimulant meds. How many times have I brought up Wellbutrin in my lectures? Like, I'm pretty sure this is like tattooed on your arms. Why we use it? It's such a versatile drug. Guanfacine, um, used for adolescents with comorbid diagnosis of conduct disorder, ODD, oppositional defiant disorder. So, Provigil, modafinil. So, these drugs, they're non-stimulants and they're very good also for ADHD. Okay. Clonidine is an antihypertensive, very good for anxiety, utilized very commonly. Okay. Wow, we're done.